Bismillah ar-Rahman ar-Rahim. I am with you, Dr. Ahmed Elzayady. Today we will complete the portfolio of the bleeding in early pregnancy by gestational trophoblastic disease. Gestational trophoblastic disease is the spectrum of the trophoblastic proliferative disorder. Any abnormal proliferation of the trophoblast or the part that will later forming the chorionic villi, forming the placenta. This is called gestational trophoblastic or trophoblastic proliferative disease or gestational trophoblastic disease. If it is had the benign attitude, it will be described as a vesicular mole or hydatiform mole or molar pregnancy. If it is persistent, or if it is invading the wall, or if it has the metastasis outside the uterus, it will be named after a gestational trophoblastic tumor, and this will be discussed in gynecology in details. Vesicular mole or the hydatiform mole or the molar pregnancy, it's a benign trophoblastic proliferation. Either part or complete part of the placenta will be replaced by a vesicular tissue. So the trophoblastic tissue, which is the part that will form the placenta and the membranes in the embryo, if it has abnormal proliferation in a benign nature, it will be termed as a vesicular mole. So either all the placenta or a part of the placenta will be transformed into vesicular structure. Regarding the types or the pathogenesis is depending on that there is something happen to the ovum that making it permit a polyspermy or permitting more than one sperm to fertilize it. If this ovum was anucleate or its nucleus was inactivated and one sperm enter into it duplicating himself, or two sperms enter into it, so it will form a embryo or a zygote that is formed of 46 chromosomes, but these 46 chromosomes all are paternal, either from a duplicated sperm or either from two sperms. And these paternal type of chromosomes will make the whole products of conception to change into vesicles. So there is no fetus, there is no amniotic fluid, there is no placenta, there is no membranes, only the whole products of conception will become vesicles. But if the nucleus of the ovum is active and just two sperms enter into the ovum, that will create a zygote that is formed of triple sets of chromosomes. So the number of chromosomes will become 69 chromosomes of both paternal and maternal sources. And this abnormal chromosome number, 969 chromosomes, will result into normal conception in structure. So you will find the fetus, you will find the cord, you will find the placenta, you will find the amniotic fluid and membranes, but the part of the placenta will be changed into vesicles. So you have the complete type, which all the sets of chromosomes, 46 chromosomes, are paternal, and there is no products of conception. All the products of conception will become vesicles. And you have the partial mole, which is both paternal and maternal chromosomes, but it's 69 chromosomes. That there is products of conception, but part of the placenta will be changed into the vesicles. The first is complete mole, and the second is partial mole. There is no risk factors of partial mole. The partial mole is happened by coincident, and it's usually associated with less complications and low level of recurrence. But regarding the complete mole, the general scheme of risk factors of oncology generally: age, parity, socioeconomic standard, race, genetic predisposition. Regarding the age, is related to the extremities of reproductive age. Regarding the parity, it is disease of primipara. Regarding the race, it's more common in South Asia. If it is general population, about 1 in 1000. In South Asia, it reached to 1%. standard is related to the low socioeconomic standard. Diet may be related to the rice and spicy food. Genetic factors, it's more common in trisomy 16. Of course, the main risk factor is a previous history of molar pregnancy. The recurrence rate is 1 to 2%. If we are discussing now the pathology, there is main difference between the complete mole and partial mole. In complete mole, by naked eye, the uterus will become above the period of amenorrhea. You have a proliferation in the trophoblast, and as we mentioned before, there is no products of conception. There is no fetus. There is no cord. There is no amniotic fluid. Only vesicles, grape-like vesicles, intercommunicating with each others, and these vesicles may reach into the wall of the uterus, and here it's become invasive mole, and may find a way through the uterine vessels into the lungs, and here it will become metastatizing mole. So the uterus is enlarged more than the period of amenorrhea, and its consistency becomes soft and dewy due to its filling by grape-shaped vesicles. In regard to the partial mole, there is fetus, there is amniotic fluid, there is placenta, so the consistency is as usual, but the period of amenorrhea, the fundal level is below the period of amenorrhea because usually this fetus growth is restricted. Regarding the microscopic examination, of course, it is changing the normal structure of the chorionic villi. We know the chorionic villi is formed by syncytial and cytotrophoblast outside, and the mesoderm and the fetal blood vessels. This will be transformed into a vesicle lined by syncytial and cytotrophoblast filled with fluid due to the hydropic degeneration of the mesoderm and absent or scanty blood vessels. This will become diffuse and severe in cases of complete mole, but in case of partial mole, only part of the placenta will be affected, so this trophoblastic proliferation villus edema are just focal and variable. In cases of ovaries, in cases of complete mole, which there is larger amount of trophoblastic tissues, so you have a high level of HCG, you may have about in 25 to 30% of cases of complete mole bilateral ovarian enlargement. It can reach large sizes up to or more than 10 centimeters, and it's of multiple variable sized vesicles. These vesicles are called theca lutein cysts, lined by luteinized granulosa and theca cells, and its management, please don't aspirate, please don't doing cystectomy or ovariectomy. You will just create or evacuate the contents of the uterus after downgrading of the HCG level. This theca lutein cysts will disappear spontaneously within 2 to 4 months of treatment of the vesicular mole. Hysterectomy with bilateral ovarian enlargement, showing the naked eye of the theca lutein cysts, and on the left side is showing the ultrasound picture of the theca lutein cyst. As you find, it's formed of multiple intercommunicating cysts, and it reached to the large sizes up to or more than 10 centimeters. Complications is related more to the complete mole, related more to the increased level of HCG. Regarding the maternal complications, of course, there is complications related to the intrauterine manipulation during evacuation or spontaneously. It may be related to the word chip, shock, hemorrhage, infection, perforation. It may be related to the trophoblastic embolization if it reached to the uterine vessels, so can causing adult respiratory distress syndrome. If the vesicular tissue can reach it through uterine vessels into the lungs or distant metastasis, this is called the metastatizing mole. It can cause hyperemesis gravidarum due to the HCG effect on the chemoreceptor trigger zone. It can cause preeclampsia, and here in cases of vesicular mole and twins, you can diagnose preeclampsia before 20 weeks due to the high HCG level. The HCG level has a thyrotropic activity or TSH-like action, so it can cause thyrotoxicosis. If there is major destruction of the vesicular tissue, it can release tissue thromboplastin, and this can create a cascade of extrinsic and intrinsic pathway causing consumption coagulopathy or disseminated intravascular coagulation, DIC. The fecal lutein cyst itself can cause complication like if it's torsion or rupture or hemorrhage. If you have a treatment during suction or evacuation of the uterus, can cause perforation or it can cause infection. If there is persistence after evacuation of the uterus, so this is called the persistent trophoblastic disease, and maybe long-term sequelae complications related to infertility, maybe abortion or recurrence. Of course, in the fetus, if there is fetus, in case of partial mole, you of course have abortion, IUGR, IUFD, and of course it's incompatible to the extrauterine life. How you can diagnose, first of all, in all cases of bleeding in early pregnancy, like abortion, like ectopic, and here in the vesicular mole, you should diagnose first pregnancy. What I mean that you may miss the pregnancy and the first presentation to the woman that she had an attack of bleeding and she didn't diagnose her pregnancy before that. So you should see if there is symptoms of pregnancy or not. But the classical complication is vaginal bleeding. Here the vaginal bleeding may be bright red, which is related from or caused from the separation of the vesicles and the intercommunicating blood vessels are injured. Maybe it's bright red, or maybe it's mixed red, become like brown juice discharge. Brown here means dried dried plum, which is البرقوق الناشف او اللي هو بنسميه القراصية. This is because it's mixture between the blood and the intravesicular fluid after rupturing of the vesicles. It's very rare that the woman, if she is complaining from passage of grape-like vesicles, this bleeding is usually associated by pain, and this pain may be due to the colicky pain after uterine contraction or dull aching pain due to uterine distension. If there is complication, right, uterine perforation or a fecal lutein cyst torsion, this may be presented by acute pain or acute abdomen. May be associated with symptoms of complication, like the woman is complaining of hyperemesis gravidarum or complaining from headache or blurred vision due to associated preeclampsia. The signs, of course, general, abdominal, and local. Generally, here the general signs of pregnancy, which is the breast signs, and the hypovolemia signs. Either it is related to the pallor or hypotension or tachycardia, or up to shock if there is major amount of bleeding. You may have signs of complication by elevated blood pressure or tremors due to the thyrotoxicosis. Of complete mole, you will find that the fun level is above the period of amenorrhea. The uterus is soft and dewy, and there is no palpable pulse or audible fetal heart sounds. This is all the uterus is filled by vesicles. You find the softness of the cervix, which is the early signs of pregnancy. You may find on your head vesicles or some blood, and if you do by manual examination, you may palpate the bilateral cystic ovaries, which are the fecal lutein cyst. Regarding the investigation, as all topics of bleeding in early pregnancy, you should involve the pregnancy test and its modification and the imaging represented by the ultrasound. Regarding the pregnancy test, of course, it's positive and it's high positive. It may reach to the levels more than 100,000 in cases of complete mole. In partial mole is not significantly increased. Regarding the imaging in the previous picture, you can see that the uterus is filled by heterogeneous multicystic mass, which is called snowstorm appearance or honeycomb appearance. In case of partial mole, you will find by ultrasound a fetus, placenta, cord, amniotic fluid, but the part of the placenta is changed or is replaced by multiple vesicles. Of course, the diagnosis can be sure after histopathological examination of the placenta after delivery. You have differential diagnosis with other cause of bleeding in early pregnancy with abortion. Abortion, there is intact intrauterine pregnancy or previously diagnosed intact intrauterine pregnancy, and the hallmark complaint is the bleeding. In case of ectopic pregnancy, there is empty uterus and there is adnexal mass with or without free fluid, either it's disturbed or not. And in cases of vesicular mole, complete mole is just a snowstorm appearance by ultrasound and the high level of HCG. It can be differential diagnosed with other cause of oversized uterus or fundal level above the period of amenorrhea, or it can be differential diagnosed with causes of snowstorm appearance like degenerated submucous fibroid or degenerated uterine polyp. Regarding the management, of course, if you have a major degree of bleeding, you first should resuscitate the woman, or you first should correct the anemia. So first of all, you should do blood grouping and RH typing, and if there is anemia, you should correct her, and if it is choked due to severe bleeding, you should resuscitate her. After that, you should have an X-ray to diagnose the metastasis. You cannot guarantee this is a benign one or malignant one, so you should first of all has a basic X-ray to diagnose if there is chest metastasis by cannonball appearance, and to have a HCG. And here the beta HCG is not for diagnosis. This as baseline level for follow-up later. The main line of treatment of cases of vesicular mole is evacuation of the contents of the uterus. But if you just enough, or if you just finish your management by evacuation of the uterus, you are now missing the cases of persistent trophoblastic disease, or you are missing the cases that had malignant potentiality. So the main management is evacuation of the uterus, and after evacuation of the uterus is the follow-up of the beta HCG level to reach to the non-pregnant levels. So after you correct the anemia, having the basal X-ray and the basal HCG, do the evacuation of the uterus, and the main line of treatment for evacuation of the uterus is suction evacuation and curettage. The suction evacuation of the and curettage, you dilate the cervix, you put a plastic catheter. This plastic catheter is introduced into the uterus, ultrasound guided. You evacuate the uterus under coverage of antibiotics, and then after finishing your evacuation, you can give ecpolix. Ecpolix preferable to not use during the maneuver, because uterine contraction can during the evacuation can introduce trophoblastic tissue into the uterine vessels, which may favor the trophoblastic emboli. Of course, you may have complication with this maneuver like shock, hemorrhage, infection, but the favorable type of, or the favorable rule of management for evacuation of the uterus contents in case of vesicular mole is suction evacuation of curettage, ultrasound guided. You correct the anemia first, you give the ecpolix after finishing the procedure, and then you send the whole contents to the histopathology for confirmation of the diagnosis. Methods: if the uterus is large sized and there is a fetus inside, like in case of partial mole, you can use the medical evacuation. In cases of there is severe amount of bleeding and the uterus or the cervix is still closed, you may do hysterectomy. Hysterectomy is not superior, but you can do hysterectomy in very rare cases, in case of uterine perforation or the patient is more than 45 years and she is not need for further fertility. Maybe medical evacuation, surgical evacuation, hysterectomy, hysterectomy, but again and again, the main line of treatment is suction evacuation. After suction evacuation, you didn't finish the management yet, you should do the follow-up. The follow-up aiming for early detection of malignant transformation. First of all, you are following up by detection of the HCG level, and the detection of HCG level can be misinterpreted in cases of pregnancy. So you should affirm that the woman will not get pregnancy using contraception for at least 1 year. The new guidelines is speaking about for at least 6 months after the HCG become negative, and the best method for that is the combined pills, combined estrogen and progesterone, because combined pills suppress LH, and by suppressing LH it can suppress HCG by their cross reactivity, so it can help in the reduction of the level of HCG. So you do and you do a serial measurement of the beta HCG. You are measuring the beta HCG 48 hours after evacuation, and then weekly until it become negative, and then for 3 successive negative. If it's become negative for 3 successive measurement, you will follow up it up to 6 months after complete resolution. Usually it is resoluted or returned to normal within 56 days or within 8 weeks. If there is plateau, so the HCG is not decreased, or decreased then increased again, or it is decreased and then increased, so if it is plateau or decreased and then increased, or it's persistent increasing, this is diagnosing for persistent trophoblastic disease, and here you need management, further management by chemotherapy, and this is now transformed into gestational trophoblastic tumor, which will be discussed later in gynecology. So if it is decreased or increased after evacuation, this is persistent gestational trophoblastic disease, and it will be further managed by chemotherapy. What are the features suggesting development of choriocarcinoma or persistent trophoblastic disease? As we mentioned, plateau or increase then decreased, or it's become positive after being negative, or there is persistent or new vaginal bleeding, subinvoluted uterus, persistent cystic ovaries, or appearance of symptoms and signs of secondary. Sometimes the first sign of metastasis is hemoptysis because of lung metastasis. This is an example. Factors for development of gestational trophoblastic disease, gestational trophoblastic tumor after vesicular mole: if the age is more than 40, if it is a recurrence, if the beta HCG is more than 100,000 milli international unit per milliliter, or the thecal lutein cyst is more than 6 centimeters. As a take-home messages in cases of, or in the topic of gestational trophoblastic disease, it's under the umbrella of a category of trophoblastic proliferation or abnormal trophoblastic proliferation. This abnormal trophoblastic proliferation, if it is benign, it will be named after the vesicular mole. If it is persistent after evacuation, and this persistence is diagnosed by maintaining high level of HCG, this is now under the umbrella of gestational trophoblastic tumor, and this means it will need chemotherapy, and this will be discussed in gynecology. In cases of vesicular mole, you are dealing in one of the topics of bleeding in early pregnancy, of 2 types. Complete mole, all products of conception are transformed into vesicles. It is of high level HCG. It is due to 46 chromosomes, but all are paternal. In cases of partial mole, it's 69 chromosomes, both paternal and maternal. Here in partial mole, all products of conception are present as it is, but part of the placenta is transformed into vesicles. Most of complications is related to the complete mole because of the high level of HCG. The hallmark of diagnosis is vaginal bleeding with high level of HCG and snowstorm appearance by ultrasound in case of complete mole. The main line of management is suction, evacuation, followed by follow-up. First of all, you do resuscitation, then you do basal HCG and X-ray, then you do suction evacuation, then you follow up the reduction of HCG to the non-pregnant level, and then 6 months after that, if it is persistent HCG or increased after reduction, or it is increasing, this is diagnosing for persistent trophoblastic disease, or what's called gestational trophoblastic tumor. Thank you very much for your listening.